This video will explore the structures of the root of the neck. Let's take a look at the branches of the subclavian artery first. The subclavian artery is divided into three regions based on its relationship to the anterior scalene muscle. You might recall that the brachiocephalic trunk originates from the arch of the aorta, and here in the root of the neck, this trunk divides into the common carotid artery, shown here by the X, and the right subclavian artery, indicated by the numbers 1, 2, and 3. Therefore, the first portion of the right subclavian artery is situated between the origin of the subclavian, here, and the medial border of the anterior scalene muscle, as shown here. And from this first part of the subclavian artery arises three different branches. You are already familiar with one branch called the internal thoracic artery. We saw this branch in the thorax flanking the sternum to give off the anterior intercostal arteries. Now you're seeing the internal thoracic artery at its point of origin. The largest branch to arise from the subclavian artery is the vertebral artery. This artery ascends in the neck within the transverse foramina of C1 through C6. This artery will enter through the foramen magnum in order to supply the brainstem and will give off branches to supply the spinal cord. And the third branch arising from the first part of the subclavian artery is referred to as the thyrocervical trunk. We'll discuss this branch in more detail on the next slide. The second part of the subclavian artery is situated immediately posterior to the anterior scalene muscle, as shown here. Arising from the second part of the subclavian artery is the costocervical trunk. The costocervical trunk will give rise to a deep cervical artery, which is shown here in relief in the background, and it will also give rise to a supreme intercostal artery, which descends to supply the first intercostal space. You might recall that the superior thoracic artery, arising from the first part of the axillary artery, was responsible for supplying the first intercostal space anteriorly. This supreme intercostal artery is going to supply the first intercostal space posteriorly, and again it's arising from the costocervical trunk, which is branching from the second part of the subclavian artery. And lastly, arising from the third part of the subclavian artery is the dorsal scapular artery, as shown here. You might recall from previous lectures that the dorsal scapular artery is responsible for supplying both the levator scapulae muscle and the rhomboids. Now let's take a closer look at the thyrocervical trunk and its branches. Again, the thyrocervical trunk arises from the first part of the subclavian artery, which is shown here. This trunk will give rise to three different branches. The first branch is referred to as the inferior thyroid artery. This artery, as its name suggests, will supply the inferior poles of the thyroid gland. Arising from the inferior thyroid artery is a small branch that ascends along the anterior aspect of the anterior scalene muscle, referred to as the ascending cervical artery. Also arising from the thyrocervical trunk is the transverse cervical artery. And as you might recall, this artery is responsible for supplying the trapezius muscle. And the third branch arising from the thyrocervical trunk is the suprascapular artery, which you now know is responsible for supplying both the supraspinatus and infraspinatus muscles. During lab, do take the time to find and identify these branches of the thyrocervical trunk. Here is a slightly different perspective of the costocervical trunk, which again arises from the second part of the subclavian artery. Here the costocervical trunk is giving rise to a deep cervical artery, which supplies the musculature of the back, and it's also giving rise to a supreme intercostal artery, which will supply the first intercostal space posteriorly. Also from this image, you can appreciate how the vertebral artery, arising from the first part of the subclavian artery, courses superiorly to enter into the transverse foramen of C6, and it courses through all of those foramina, all the way up to the transverse foramen of C1. From there, it enters into the foramen magnum in order to supply both the brainstem, and it gives off branches to supply the spinal cord. Recall that only the vertebral vein courses through the C7 transverse foramen. In this image, you can appreciate the position of the thyroid gland. Notice how it sits anterior to the trachea, just below the larynx. Specifically, it sits below the cricoid cartilage. Notice how the isthmus of the gland, which connects the two lobes, the left and the right, sits over roughly the second to the fourth tracheal rings. And to remind you, during a tracheostomy procedure, the surgeon must place the endotracheal tube between usually the fourth and fifth tracheal rings so as to avoid the isthmus of the thyroid gland. So let's suppose that the endotracheal tube is placed roughly here. But do appreciate this is the area where those inferior thyroid veins descend to drain into the brachiocephalic veins. So you must be careful as a surgeon entering this area with the scalpel and the endotracheal tube. If possible, the inferior thyroid veins are spared during this procedure. Also shown in this image is a pyramidal lobe of the thyroid gland, indicated here. This is a remnant of the thyroglossal duct, from which the thyroid gland is derived embryologically. Functionally, the thyroid gland is an endocrine gland, meaning that it secretes hormones. It secretes hormones which are important for metabolism, such as thyroxine and triiodothyronine, and it also secretes calcitonin. As you might recall, calcitonin inhibits bone resorption, thereby lowering serum calcium levels. Because the thyroid gland is an endocrine gland, it has a very rich blood supply. From above, this gland is supplied by the superior thyroid artery. From below, it is supplied by the inferior thyroid artery, which again is a branch of the thyrocervical trunk. By way of venous drainage, it has three routes of drainage. The superior thyroid vein is going to drain directly into the internal jugular vein. So too will the middle thyroid vein. However, the inferior thyroid veins will drain directly into the brachiocephalic vein, whether the left or the right. In addition to the thyroid gland being supplied by both the superior and inferior thyroid arteries, in about 10% of the population, the gland can also be supplied by a thyroid ima artery. Here in the bottom left of the screen, we see a thyroid ima artery originating from the brachiocephalic trunk and coursing superiorly to the isthmus of the thyroid gland. This artery can also arise from the aortic arch directly. Notice how centrally located this artery is along the anterior wall of the trachea. During tracheostomies for long-term management of an airway, surgeons must be on the lookout for this artery just in case it is present. If this artery is accidentally compromised, the surgical field will fill quickly with blood. Being cognizant of this artery is also important for thyroidectomies. Embedded in the posterior aspect of the thyroid gland are 4 to 6 parathyroid glands, which secrete parathyroid hormone for calcium homeostasis. As you might recall, parathyroid hormone is responsible for increasing serum calcium levels. The parathyroid glands are supplied by both the superior and inferior thyroid arteries. These parathyroid glands can be very difficult to find during dissection. If you happen to locate one, it will look like a small bean that is either brown or tan in color. This image is also useful for reinforcing key relationships between nerves and arteries. Let me remind you that the external laryngeal nerve courses in close proximity to the superior thyroid artery. During division of the superior thyroid artery for a thyroidectomy, the external laryngeal nerve must be preserved. Similarly, there is a very close relationship between the recurrent laryngeal nerve and the inferior thyroid artery, which crosses over top of it, or even behind it, as you see here. Again, during division of the inferior thyroid artery for a thyroidectomy, the recurrent laryngeal nerves must be spared. Surgeons always take great care to identify, isolate, and preserve these nerves before they divide these vessels. The suspensory ligament of the thyroid gland, known by surgeons as the ligament of Berry, shown here, is a band of connective tissue that affixes the thyroid gland to the trachea and sometimes to the cricoid cartilage. During a thyroidectomy, this ligament must also be divided, but again notice its close relationship to the recurrent laryngeal nerves. So again, great care must be taken to divide this ligament carefully without damaging or injuring the recurrent laryngeal nerves. A goiter is a non-neoplastic and non-inflammatory enlargement of the thyroid gland, which is usually the result of a lack of dietary iodine. As a result of enlargement, the thyroid gland will migrate in all directions except it will not migrate superiorly. This is because of the very restrictive attachments of the sternohyoid and the sternothyroid muscles which overlie this gland. Enlargement of the thyroid gland can certainly compress nearby structures, including the trachea, the esophagus, and/or the recurrent laryngeal nerves. As such, a patient could present with signs and symptoms such as dyspnea, dysphagia, or even hoarseness of voice. Here is another look at the parathyroid glands, which again are very small ovoid-shaped glands located on the posterior aspect of the thyroid gland. There are typically 2 parathyroid glands per lobe of the thyroid gland. Therefore, we have a superior parathyroid gland and an inferior parathyroid gland per lobe. If it is possible during a thyroidectomy, parts of the thyroid lobes can be preserved in order to protect both the laryngeal nerves and to spare the parathyroid glands. Recognize that inadvertent removal of the parathyroid glands can lead to a condition called tetany. Tetany presents as intermittent muscular spasms, which is caused by a loss of parathyroid hormone and a consequent deficiency of calcium. So to reiterate, during a thyroidectomy, the surgeon will do his or her best to preserve and spare as many parathyroid glands as possible. Previously, we discussed the sympathetic trunk and ganglia at length as they related to the thorax. Now let's take a look at the sympathetic trunk in the cervical region. Within the head and neck, sympathetics are responsible for a variety of functions. For example, they will vasoconstrict all the blood vessels of the face and neck. Sympathetics will also decrease salivary gland activity, and they will increase heart rate and cardiac contractility via the cardiac nerve fibers. Sympathetics also innervate the dilator pupillae muscle of the eye, as well as the superior tarsal muscle associated with the upper eyelid. And don't forget that sweat glands of the face and neck are also innervated by sympathetic fibers. The cervical sympathetic trunk extends to the level of the first cervical vertebra, and in relationship to the carotid sheath, it is positioned just posterior to the carotid sheath. Recall that the carotid sheath contains the internal and common carotid artery, along with the internal jugular vein and the vagus nerve, but it does not contain the sympathetic trunk. Within the neck, the sympathetic trunk receives no white rami communicans. Recall that white rami communicans are found between the levels of T1 and L2. Within the neck, there are, however, 3 cervical ganglia. There's the inferior, middle, and superior cervical ganglion, the largest of which is the superior cervical ganglion. Here's the middle cervical ganglion. Oftentimes, the inferior cervical ganglion fuses with the first thoracic ganglion, and when that happens, we call that a stellate ganglion. Notice that arising from the superior cervical ganglion is the internal carotid nerve, shown here, which contributes to the internal carotid nerve plexus. This is how sympathetic innervation makes its way to various structures of the head. This nerve jumps onto the vessel and forms that vascular highway. While it is true that several cardiac nerves, as well as gray rami communicans, descend from these cervical ganglia. At this point in time, I don't want you to concern yourself with that level of detail. Do be on the lookout for the sympathetic trunk and these cervical ganglia during your dissection. This slide is intended to review the pathway by which sympathetic fibers course from the spinal cord to their target structures in the head and neck. Recall that the preganglionic sympathetic fibers originate in the lateral horn of the spinal cord, and from there they exit through either T1, T2, or T3, and even T4 to make their way onto the sympathetic chain. Once inside of the sympathetic chain, they can ascend through the cervical trunk and can synapse here in the superior cervical ganglion, for example. After this synapse has occurred, the postganglionic sympathetic fibers can exit via the internal carotid nerve and can make their way onto the internal carotid artery. And from there, they follow this vascular highway to their target tissues in the head. The image shown here to the right simply reinforces the fact that the internal carotid nerve originates from the very top of the superior cervical ganglion, and from there, it literally jumps onto the internal carotid artery. And lastly, here are some reminders of additional structures you will see in the root of the neck. For example, don't forget that the phrenic nerve courses along the anterior surface of the anterior scalene muscle in order to pass into the thorax between the subclavian vein and the subclavian artery. Additionally, within the root of the neck, be on the lookout for the thoracic duct as it empties into the left venous angle. During dissection, you may find that the thoracic duct is filled with venous blood due to a backflow of blood into the duct. And lastly, this slide is meant to serve as an overall summary of the structures of the root of the neck. Do take the time to review this slide so that you can appreciate the relationships of structures to one another. This concludes the video on the structures of the root of the neck. Happy studying!